Hi, everyone, and welcome to episode 108 of the Veterinary Behaviour Chat podcast. And today I thought we would have a little chat about the medication classes that are the SSRIs and the TCAs. So SSRIs are our selective serotonin reuptake inhibitors, and the TCAs are our tricyclic antidepressants. And I wanted to chat about these because there are a lot of similarities between the two or among the two, but there are also quite a few differences. And I just wanted to chat through the similarities first and then maybe the differences afterwards, just to give you a bit of an overview of when you might use them, what situations you might use them, when you might choose one over the other, what the advantages and the disadvantages of both of them are, because I think sometimes that can get a little bit confusing. And especially when we're sort of making first medication choices, we're sometimes not sure, what do I reach for first, right? Do I go for an SSRI? Do I go for a tricyclic antidepressant? What options do I have? What are the pros and cons of each? So I thought I would go through those a little bit. So before we get started with the similarities and the differences, let me quickly tell you what medications fall into the category of the SSRIs and what medications fall into the category of the tricyclics. So our SSRIs, really commonly used in veterinary behavior medicine, fluoxetine, but also fluvoxamine. So that's a slightly different medication. Don't get the two confused, fluoxetine versus fluvoxamine. And then also relatively commonly used sertraline, paroxetine, and maybe escitalopram. So we've got quite a few there. There is also citalopram that falls into that category, but we don't really tend to use that much in veterinary behavior medicine because there was one study done on a group of Cavalier Spaniel dogs. I think they were Cavaliers. Not sure if that's right, but it was a group of dogs, and many of them had cardiac adverse events, side effects causing fatalities. So citalopram is not something that's commonly used, but escitalopram, which is very similar to citalopram, is quite commonly used. So those would be the main medications that fall into the SSRIs. Fluoxetine, obviously the most common one there. And then for our tricyclic antidepressants, we've got quite a few. Again, the most commonly used one will be clomipramine. You'll be familiar with that as Clomicalm, or Clomav is another kind of trade name. But also in this class are a slightly older medication, which has been quite commonly used in the past or traditionally, which is amitriptyline. And then we have a couple of others that are maybe not quite as common. So we've got imipramine, desipramine, doxepin, which is an interesting one, and also nortriptyline. So those are some of the other medications that fall into the category of the tricyclic antidepressants. So I think let's get started on what are their commonalities, what are their similarities, and then you'll start to see kind of where I'm going with this, and then we'll move on to what the differences between the two groups are. So similarities. Both groups belong into the category of what we call antidepressants and what in human psychiatry is termed antidepressants. Now, this can sometimes be a little bit confusing, I guess, in veterinary behavior medicine because we don't really we don't have a diagnosis that is depression as such for our pets. So when I sort of say to clients, I'd like to try and use this medication, and they're familiar with the term antidepressant in human psychiatry, then they often ask me, is my pet depressed? And I say, well, no, not really. And that's also not really a diagnostic criteria or a diagnostic term, I guess, that we would use in veterinary behavior medicine. But certainly these medications have a lot of characteristics that could be really beneficial for us for the presenting behavior signs that we see for our veterinary patients. So they both belong into this category of antidepressants. Now, they're both what we would term long-acting medications. And if you're not quite sure what long-acting versus short-acting medications mean, have a look at my the Professional Guides ebook that has just recently launched. There are some amazing cheat sheets in there that give you a bit of an overview of what are long-acting meds versus short-acting meds. What would you use kind of those long-acting versus short-acting medications for? What are their indications? What might be the context that you might use them for? But certainly the SSRIs and the TCAs both fall into the group of long-acting medications, which means they both have an onset to effect of about 4 to 6 weeks. So it takes some time before these medications become fully effective. And they're both intended to be given every day, sort of on an everyday basis for the long term. And when we talk about long term, we're talking months to years, maybe even lifelong. So these are not event medications that you would only give for a short period because they take such a long time to actually start working properly. So they're not something that we give before a veterinary visit, before owner departures for separation-related behaviors, or for, even just maybe for a couple of weeks when there is a change in circumstance or a change in environment. These definitely are intended to be given for the long term. And that's also because they both have relatively similar neurobiochemical, actions, the way that they sort of work, how they work on our neurotransmitters. Now, another similarity is that they both primarily function on the serotonin neurotransmitter pathways in the brain. And when we get to the differences slightly later, you'll see that the tricyclic antidepressants have a slightly a secondary effect on the noradrenaline neurotransmitter system and pathway, but primarily they have their main effect on the serotonin pathway. And they both block serotonin reuptake, so they both work on those kind of reuptake enzymes, if you like, or those reuptake transporters. So they have a relatively similar pharmacological action, if you like, on those serotonin pathways. So that's another similarity. Both of them are non-addictive. So that's something also that clients will often ask, is there going to be dependency? Are they addictive? How easy will it be to wean my pet off these medications? Now, coming off medications is a kind of a whole topic in itself, if you like. And if you're interested in more of that, then my psychoactive course is brilliant for that. We talk a lot about this, like a whole kind of module stroke lesson about stopping medications. How do we do that, and how do we safely do that? But essentially, both of these classes are non-addictive and don't have dependency. One really big similarity that these two groups of medications have is around learning. So they are both unlikely to negatively affect learning. So that's really important when we are maybe combining our psychopharmaceutical approach, maybe with a training approach or a learning approach. We want to make sure that we're using medications that don't inhibit learning, that don't negatively affect learning. And neither of these groups do. And actually, in fact, they both actually facilitate learning. So they have these initial effects whereby, serotonin is increased in the short term in the synapses, but actually in the long term, they have further psychopharmaceutical actions that go beyond kind of the immediate serotonin increase and actually build new receptors, new proteins, and affect pathways and cascades in the postsynaptic neuron that are really common with some of the cascades or effects that actually affect long-term potentiation and learning. So actually, if we're using SSRIs or TCAs, both classes have this really positive effect, long-term effect on learning, and might actually even ease or facilitate learning and create that environment where then training or behavior modification can come in and create a really strong learning response. So that's something that's really amazing in terms of both of these medications. Both are used to treat relatively similar behavioral presentations or signs. So both of them are used in anxiety disorders, fear disorders, phobias. They're both used in compulsive disorders in our pets, also known as abnormal repetitive behaviors. Both can be used in presentations such as urine marking in cats. So they're actually, they have a relatively similar, effect in terms of the behavioral presentations that they're really useful for. So, if we're thinking about, which medication should I choose? And we'll talk a little bit about that when we talk about the differences, but probably the SSRIs and the tricyclics, if you're thinking about, we've got a generalized presentation which is affecting the patient on an everyday basis, such as a generalized anxiety disorder, such as generalized fear presentations. And when I talk about generalized, I mean in more than 3 contexts, or in 3 or more contexts, I think is more correct to say. So if we're looking at something that is really affecting the patient on a day-to-day basis, it's this anxiety that's pervasive, that's ever present, that's there all the time, then both the SSRIs and the tricyclic antidepressants could potentially be really useful. Both of them have a licensed veterinary formulation. So this is really important if you're following a sort of a cascade approach. So for example, if you're practicing in the UK and you're following the UK sort of prescribing cascade, and you maybe want to use something first that actually has a veterinary license, then the SSRIs and the tricyclics both have a licensed medication in them. So for the SSRIs, that would be fluoxetine, which is Reconcile. And for the tricyclics, it's Clomicalm, as I mentioned earlier. So it's clomipramine, is the medication, and the licensed formulation there is Clomicalm. And I think now they're actually, the license has expired, I think. And so we've got more trade names coming up, such as Clomav, for example. Now, really important to note that both medications are only licensed for dogs and only licensed for the use in separation-related behaviors. So the license is very specific, right? It's for dogs, it's not for cats. I think in Australia they have a license for cats, but not in Europe, not in the US. And it's a canine specific license, and it's only for the presentation of separation related behaviors. So if you are treating a dog that has maybe generalized anxiety or generalized fears, or you're using the medication to treat abnormal repetitive behaviors, then you still need to get informed consent from the client, because it's not the specific indication that the medication is licensed for. However, it's licensed, so that gives us a little bit of a plus point in our ease of use, or maybe using either of those medications as our first choice. Both of them are oral medications, so whether that's a pro or a con, but they're both oral tablet presentations. They're both daily presentations. For dogs, they're both given on a daily basis. Now, fluoxetine, or I guess it varies between the SSRIs and the TCAs as to how many times a day they're given, but they're an everyday oral medication. Now, that might be great if your patient is really good at taking oral medications. We also don't have some of the problems that we might have, for example, with injectable presentations. So let's say, owners that give insulin injectable at home, that's not something we need to worry about. These medications, they're oral, they're given on a daily basis. But of course, if we have a patient that really resists oral medication, or where it's quite difficult to get the medication into them, oftentimes we encounter these problems with cats, then that can be a downside, right? That can be a negative. Sadly, we don't yet have any good transdermal applications, certainly of these medication groups. There were some studies done on transdermal fluoxetine that had quite poor results, poor outcomes. So transdermal fluoxetine only has about 10% of the bioavailability of an oral presentation or formulation. So it can either be a pro or it can be a con. Many patients take oral meds really easily, especially dogs, and many cats once you find a really good way of administering them. But I've actually had treatment fails with oral medications, also in dogs, both in dogs and cats, because we simply weren't able to consistently, without causing stress, get the medications into the patient. So that's something to consider. But we're in the same boat with both of them. Both medications can't be used in conjunction with monoamine oxidase inhibitors, such as selegiline. And if we are switching from an SSRI or a tricyclic antidepressant to a monoamine oxidase inhibitor, such as selegiline, we have quite a long washout period for both of those medication groups, at least 2 weeks, and for fluoxetine, 5 weeks washout between the SSRI / TCA and a monoamine oxidase inhibitor. So that's something you need to be mindful of. If you are perhaps thinking about switching to a monoamine oxidase inhibitor down the road somewhere, it's not something that happens commonly. It's certainly not a huge consideration when I sort of think about these medications, but it's definitely something to be aware of. And then because of their main action on the serotonin pathway, both medication groups have potential to cause serotonin syndrome if they are either on their own or if they're paired with other serotonergic agents. So that's important to note in both of those. And then finally, both have pretty extensive literature behind them. So we've got quite a lot of studies, some placebo-controlled trials, and a lot of case reports, case series, retrospective, prospective studies in both of these medication groups. Now, I'm not saying every single medication within the group. So we might have definitely more research in fluoxetine than we do in fluvoxamine or escitalopram, for example. And we might have more research on clomipramine than we do in imipramine or doxepin or even amitriptyline. But certainly both medication groups or classes have literature behind them, which is nice to know. So I think that kind of covers pretty much the similarities. So there are lots, right? There are lots of similarities, which is nice. But we definitely also have some differences. And the first kind of big difference would be that the tricyclic antidepressants also have, and albeit lesser, but they do have an effect on the noradrenaline pathways. So if we are wanting to regulate noradrenaline as well as serotonin, then maybe a tricyclic antidepressant might be a good choice. Now, when might we want to affect the noradrenaline pathway or regulate noradrenaline more? Well, that might be those patients that are hypervigilant, hyperattentive, very restless, very sort of high arousal. Those are often the times that we want to think about re-regulating noradrenaline. And maybe also if we're thinking that we might have a chronic pain part in our presentation, then noradrenaline is definitely better than serotonin in those descending pain pathways at modulating pain. So if we're wanting a little bit of more of a noradrenergic effect, then maybe a tricyclic antidepressant might be helpful here. And certainly amitriptyline is one of those medications that if we do have chronic pain, that could potentially be really useful. Now, we do have one SSRI that has very mild noradrenergic effects, and that's paroxetine. So if we're thinking, I definitely want to use an SSRI, but I want a little bit of a noradrenergic effect, then paroxetine could be a good one. But that effect is pretty mild. It's quite insubstantial. And if you're wanting to affect the adrenaline pathways, then you might be thinking about a tricyclic antidepressant or maybe something like an SNRI such as venlafaxine. Now, the other thing I'm going to say about the tricyclic antidepressants, which is a little bit different, I guess, to the SSRIs, is that they have a lot wider receptor profile. And because of that, and I'll talk you through kind of the other receptors that they do affect other than the sort of serotonergic and noradrenergic pathways. Where else do they have effects? And because of that, I often refer to them as slightly dirtier medications, right? They're not as receptor or neurotransmitter specific as some of the SSRIs, in particular, something like escitalopram, right? Escitalopram is very specific to serotonin and doesn't have a lot of other effects. Now, some of the other SSRIs do. So we know that sertraline has a dopaminergic effect. Paroxetine, as I mentioned, has also a noradrenergic effect, very mild, but there are some sort of other receptor effects going on there. And then we also know that, for example, fluoxetine targets that 5-HT2C. It's a serotonin receptor, but it can cause additional side effects. So you have to kind of know the medications within the class a little bit better. But as a whole, the tricyclic antidepressants tend to have slightly more side effects because of some of the other effects that they have. And I'll talk you through them right now. So the tricyclic antidepressants have anticholinergic side effects because they block the muscarinic cholinergic receptors. And so what are anticholinergic side effects? So that can be urinary retention or constipation. You can get dry mouth. You can sometimes get blurry vision. We maybe aren't as good at being able to sort of detect that in our veterinary patients, but certainly we don't want to use those medications if we have glaucoma, for example. So that would be a contraindication, patients with glaucoma. So those anticholinergic effects, or if we have elderly patients, that's not great for cognition, memory, learning. So we want to avoid them in older patients because of these anticholinergic side effects. So those are things I would be thinking about with the tricyclic antidepressants when I might not use them. The tricyclic antidepressants also block the H1 and H1 histamine receptors. So we get this antihistamine effect, which is why the tricyclic antidepressants can often flatten, in inverted commas, our patients quite a lot. So cause quite a lot of drowsiness and lethargy, as you would expect with an antihistaminic effect. And that's why amitriptyline can oftentimes be quite unpleasant from a side effect profile, because amitriptyline has quite an extensive sort of antihistaminic effect, especially in cats. Amitriptyline can be really flattening in cats, and a lot of clients really don't like seeing their cats like that. So that could be a reason not to use amitriptyline, for example. And then doxepin, which is another of the tricyclic antidepressants, actually blocks the alpha-1 and the the H1 and the H2 histaminic receptors. So that's why doxepin sometimes is used in maybe itchy cases, patients that present with sort of additional skin or itchiness or allergic type presentations, or maybe even those patients that have an abnormal repetitive behavior, which is to do with maybe licking or chewing, excessively licking or chewing. So sometimes it's used in acrylic dermatitis quite successfully. So those would be very sort of specific indications where that antihistaminic effect might be desired, but oftentimes that antihistaminic effect is not desired because it causes this flattening and this lethargy. So something to be really aware of. We also have blocking of the alpha-1 adrenergic receptors. So that can sometimes cause hypotension or dizziness. So again, something to bear in mind, maybe if we have a patient with underlying cardiac issues. And that then brings me to the next thing that tricyclics can do, and that is the blockade of the voltage-sensitive sodium channels in the heart and the brain. And that can cause seizures, cardiac arrhythmias, cardiac arrest. So tricyclic antidepressants definitely wouldn't be a good choice if we have a patient with seizure history or a patient with cardiac history as well. So, definitely some contraindications to think about there, where we might then choose an SSRI over a TCA if we definitely want to choose from those two groups. So yeah, the tricyclic antidepressants definitely are a little bit different in their sort of side effect profile and in some of the other things that they do. And I think that's why they've also fallen out of favor a little bit, I would say, in terms of their use, because of these side effects that we see perhaps more commonly with tricyclic antidepressants. We definitely don't want to use them in older patients. We don't want to use them in patients with seizure history or cardiac history. And we want to be kind of quite circumspect about choosing them. However, having said that, in some cases, they can be very beneficial if we want to have that additional noradrenergic effect, or if actually slowing the patient down a little bit is something that we actually want to achieve. Now, between the tricyclic antidepressant medications, I've already mentioned a few, right? Clomipramine, amitriptyline, imipramine, doxepin, nortriptyline, desipramine. There are quite a few. They vary in their serotonin versus noradrenaline kind of effect. So some of them will be more serotonergic, such as clomipramine, for example. Some of them will be more noradrenergic, such as desipramine, for example. So again, if we're getting really down into the nitty gritty of it and, choosing a specific medication over another, then we can start to look at some of these things. Imipramine is a very good medication. So it's used in human psychiatry for bedwetting in children. So if we have patients that have this, urination is part of their sort of those presenting signs, that kind of super fear-based urination, maybe imipramine might be something we want to choose, but we're really getting quite specific and quite nitty-gritty here into the individual medications. I think for the general practitioner, the big things to know are, what are the similarities, and almost, whether you choose a tricyclic antidepressant or an SSRI, especially the commonly used ones like fluoxetine and clomipramine, are you going to make a huge mistake if you choose one over the other? Probably not, because as a whole, they're quite similar. But if we have some specific things that we want to achieve, we might choose one over the other. And if we are looking for that additional noradrenergic effect from the tricyclic antidepressants, we might want to go there. So those are probably some of the main takeaways or some of the big points. But it's just really interesting for me to go through the similarities and the differences. And actually, some of these things come up in our exams. So these would be some exam questions, right, that we would think about. So that came up in my Australian New Zealand membership exams, but also in my American European board exams, not in such detail as, or, not as an essay question as I've just kind of presented it to you, but knowing the similarities and the differences of these medications and when we might choose what is really interesting to look at. And I think, if you're diving deeper into veterinary psychopharmacology, these are going to be some of the nuances and the sort of the little sort of tidbits that you're going to love when you're thinking about, what should I choose for this patient or this patient? And if you are interested in that, then absolutely visit my psychoactive course. I'm going to put the link in the show notes for you. That is, if you're interested in veterinary psychopharmacology, it's such a great course to dive into. It's going to give you a lot of this sort of detail that I've just spoken about. But if you're a general practitioner and you just want to have a little bit of a better understanding of some of these medications, I think my professional guides ebook is going to be so useful for you, because I do absolutely go into some of the long acting versus short acting sort of thing, making medication choices. And I have started to put into that ebook some specifics around some medications. So I'm going to build on that. And if you get the ebook, you have lifetime access. So as the ebook is updated, you get all the new guides and resources and cheat sheets that come into that. And if you would like something in particular for me to put into that guide, into that ebook, then absolutely drop me an email or drop it, in the comments section here of the podcast, and just let me know, I'd absolutely love a guide on XYZ. And if I get enough people asking for the same thing, then I will absolutely create a guide or a resource, a handout, a cheat sheet on that particular thing. So you can be very much involved in what actually goes into that ebook. So I'm putting the link to the ebook in the show notes as well. So if you want to go and have a look at the pages, get some more information about the ebook, but also the psychoactive course, then feel free to browse, have a look, and if it's for you, then go ahead and join the course or purchase the ebook. All right. I hope you found this useful. I find it really fascinating. So I love talking about this level of detail about these medications, but hopefully I've given you a big picture view, but also a slightly more granular view of some of these medications, and definitely the similarities, but also the differences between them. All right. I very much look forward to seeing you in the next episode, and have a lovely week. Until then, bye for now.